Thank you and welcome to my presentation on non-invasive spinal electrical stimulation, also called NISE Stim. My name is Gerti Motavalli and I'm a physical therapist in Florida, USA. This presentation is made for both parents and therapists and physicians. So I will go a little bit back and forth in terms of using lay terms and also some technical terms. So a little bit about myself. I am a physical therapist. I did my initial training in Germany in 1984, so 40 years ago now. I have always worked in pediatrics. I got my master's in physical therapy from the University of Missouri, Columbia in 2000. In 2017, I started to develop the spinal electrical stimulation protocol together with Dr. Gardalan. He's a very well-known researcher in the field of electrical stimulation. And since we had really good responses with the treatment, we published in 2019 in the magazine Child Neurology Open about a case study about the first child we started spinal electrical stimulation with. And then in 2023, I presented at the World Conference for Spina Bifida. I have a clinic in Florida, USA, and I see patients from around the world. I have treated over 200 children with spina bifida so far using my protocol. I also treat other children, but I'm really, really focused and specialized in children with spina bifida. I teach my method around the USA and around the world. And my mission really is to get the word out and have more and more therapists trained in this method so families can access it with their children. So what is NISE Stim? So NISE Stim is non-invasive spinal electrical stimulation, and I gave it the specific name to distinguish myself from the other treatments that are out there. So basically, I have electrodes over the spinal cord, either higher or lower, depending on how the child presents. And then the return electrodes, so those are the other two electrodes that are not on the spinal column, I place wherever I need to do it for helping the child. So for this particular child who has a pretty significant scoliosis, it is on the side of the trunk. Now, before I treat any child, I always get sensation and muscle testing baselines. And then I develop an individualized program specifically for this child. And as the child changes, I also change my parameters. So what is so special about spinal stimulation versus regular electrical stimulation? And it really is that when you place electrodes over the spinal cord, you activate the motor cortex, so you get improved muscle activation and strength. The sensory cortex, which basically then gives you improved sensation, and also the autonomic nervous system. And with that, you could have improved circulation, improved bowel and bladder functioning, or improved respiration. I want to clarify some terms that you might see. So spinal electrical stimulation is by definition also neuromodulation, because we excite the peripheral nerves and we are modulating their conductivity. In order to distinguish my approach from other approaches, I call my therapy NISE Stim. And the main goals for my therapy is to strengthen this nerve signal, and with the improved nerve signal, also to have improved function. Here's an explanation why electrical stimulation can show such good progress. So when I basically stimulate a muscle, then I stimulate the peripheral nervous system, but also the central nervous system. So basically the corresponding area in the brain will be stimulated as well. I told you that Dr. Gad Alon, who is my mentor, is also a researcher in the field of electrical stimulation. And this is research he did with his physical therapy students. He basically stimulated the quadriceps muscle, the thigh muscle, and they did MRIs, and they saw that the area of the brain that normally activates the quadriceps muscle got activated during that time. There is quite some interest in spinal electrical stimulation, and there have been many published studies in pediatrics about the safety and effectiveness of electrical stimulation in the last years and over the last 20 years, but especially lately, there are more and more studies coming out, and many of those are listed on my website. Whenever I'm starting spinal electrical stimulation, I'm testing for the connection between the nerve and the muscle. And the way I do that is I have one electrode on the top and one on the bottom. I connect it with my unit, and then they have a hand switch. And I slowly go up with intensity, and then I push my hand switch and see if the person either twitches with the muscles or tells me that they feel something. And so for this little girl, I went all the way up to 100. And when I push the button, there is no feeling. I connected her foot with her spinal cord. So this is all on one channel. So the foot on the spinal cord, and the intensity is only at 10. So it's like a tenth of what it was before. And now see what happens when we push the hand switch. Here's the hand switch. Can you tell me where it tickles? Right there. Good job. So she can actually feel it. So what was really amazing about this is that this child didn't feel anything when I went all the way up to 100 milliamps, which would be unbelievably painful for a person with a normal nervous system. And her mother was saying she never felt anything on her feet anyway. So then I bridged the injury. So I basically placed one electrode over her lumbar sacral spine in the area where the nerves are that go all the way down to the foot. And then I went all the way down to 10 milliamps with my intensity, which is basically an intensity that a person with an intact nervous system would feel like a little tingle, and she was able to feel that. So it was basically for the first time in her life that she felt something on her feet. That's also the way I'm explaining why children show improved sensory responses after starting NISE Stim, that by one feeling it and then the brain registering that there is a feeling, they just get that feedback loop. And as the nerve signal is strengthened, they can just feel more what's going on. Whenever I basically want to understand how easy it is to activate those muscles, I want to get an overview of the amount of denervation. So like, how good is that nerve connection? I want to map out sensation. I want to understand like what does the child feel? How high do I have to go with intensity before the child can feel anything? And also very important for all of us to show objective progress. This is the form I'm using. So depending on how the child presents, what is most important, those are the muscles I'm testing. And it is not unusual that after 4 to 6 months, I'm able to show objective progress, which basically means that the child is able to feel with less intensity, or that the muscle starts activating at a lesser intensity. So both of that would be actually showing that the signal is getting better. And I can do the nerve conduction testing in any muscle that is important for the child's functioning. So upper extremity, lower extremity, or also on the trunk.
So she was able to get the muscles to fire relatively quickly, which she said was great. But the sensation, she had it all the way up to 100 and he still couldn't feel anything. And she said for us, that would be almost unbearable. I think she said mega tickles. This really wasn't a surprise to us at all because we know that he doesn't have feeling in his feet. But her goal is for him to be able to have feeling and, if nothing else, for safety purposes.
Look up at the ceiling. No tickles?
So for this child as well, you could see that he didn't feel anything until I went up to 100 milliamps, which is the highest I can go with my Chattanooga Continuum electrical stimulation machine. It is not unusual for me to see that. For him, you saw he had a motor response. So as compared to the other child where the toes were not moving, he actually was moving his little toes. But now I want you to see what happens 3 months later at retesting. And I'm sorry, the sound is not great, but it was just an amazing
So
moment.
she was able. Tell me when I'm pushing it again, okay? Thanks. Yeah, wow. Yeah, that is crazy.
Okay.
Tell me when I'm pushing it again, okay? He also felt that I hit his knee and he cried because he felt it.
He has never been able to feel like when he slammed his knees on the concrete, it wouldn't face at all. So
Yeah.
So basically 3 months later, I used 20 milliamps. So a fifth of what I was using when I was testing him, and he could feel it. And you see like the hand switch that his mother is having is in the hand. So when you push the button, then there's power. And I have the electrodes in the same place, the top and bottom of his foot. And he was actually saying, yes, I can feel that. But even more important than feeling my E-stim is really that it changed into function so that he actually was able to feel getting hurt when he was falling and hurting his knee. For lower spinal electrical stimulation, I place my electrodes on the spine directly. So on the sacral spine, which would be all the area on the right that is marked red, and on the lumbar spine, which would stimulate all the area that is marked purple. And then I always have 2 return electrodes on the muscles that are most important to be stimulated. So this is a video that is on my Instagram, and 19,000 people saw it, and it was just a mother recording what it looks like to do the therapy. So here it is. So you're basically seeing her getting all the supplies out. I taught her where she should place the electrodes on her child. So she has them on the calf muscle, and then the other ones are again sacral and lumbar spine, which is the areas where the nerves originate that go down the legs. So these are the 2 electrodes that then have like a little space in between and get connected with the channel. So I always try to bridge the injury. So you always have one channel go to the leg and then the other one go to the spinal cord.
Up to 35. Let's start there. We work our way up. She seems to be tolerating that. To kind of push the level of intensity that remains uncomfortable. We do this a lot of times in our high chair or Percy. On the floor while we're playing, and don't think about her. This runs for 30 minutes. We do this 3 times a day. No big deal.
So I always want to honor families' times, and I know most of us are really pressed for times, the kids as well as the parents. I feel like NISE Stim does a lot of the work by itself because the machine goes on and off. So it stimulates the muscles for 10 seconds for the most part, and then it's off for 10 seconds while the children are playing, eating, or sitting in the car or doing something else. This is a 6-year-old with spina bifida, and you can see he has severe pronation. When I'm activating, he looks really good. When I let him go, he goes back into his original position. And now I'm activating, and you see that the left one is responding much faster, and the right one had that delay. So it's a slower nerve signal. And I want to show you placement, which is lumbar spine, sacral spine, and medial gastrocnemius. when I'm activating, he has some plantar flexion and better foot position. And then when I let go, he goes back into his original position. And for all of you who are physical therapists, you know how hard it is to have a child work on ankle position, especially a child that may not feel anything in their ankles. So by placing my electrodes and seeing that I get the movement that I want, I can stimulate this over and over. So this is kind of the same concept. This mother sent me these pictures where she basically showed the child standing before in pronation, and you can see that the calcaneus is kind of going to the outside and the ankle is rolling to the inside. And then below, that was like 2 months later, it's a lot better. It's not perfect yet, but it's a lot better. And on the right, you see what the therapy looks like. She's basically there kind of playing with her pacifier, and then you can see how the stimulation comes on, which is right now, and then slowly stops again. So my goal is always that it never hurts, but my goal is to actually see a muscle activation during the stimulation.
Hold it down.
So hold it, yeah. Ooh, look at that. Look what a good job you're doing. Perfect. Awesome.
Wow.
You want to do it? Okay, you push the button. Push and hold it.
Hold it down.
Ooh, look at that view. So the significance is that, for example, a child with a club foot, the muscles that would pull the foot inwards, that would pull the foot into the club foot position are really active. And the nerve and the muscles that pull the foot in the opposite directions are typically not. And so that's kind of where I have my electrode placed. And you saw that as the intensity came on, the power came on, how beautiful the child was pulling up the little toe side to get out of that club foot position into a more normalized position. Here, I want you to see like a placement on the gluteus muscle, and in the middle one is the child. She normally plays, and you see how that lower leg is always kind of falling inwards. You know, it just stays in there. And then on the right, I actually have the electrodes placed on her gluteus. I'm going to push right now. It starts a little sudden, so that's why she kind of almost falls backwards. But you see, doing the stimulation, so right now it's stimulated. Do you see how beautiful she actually turns her leg out, but also her lower leg? That's exactly what I needed, right? I needed her to activate her lower leg to kind of be in that position. And then when I let go, she falls back into her original position. I have many options where I place my electrodes. For example, specifically on the gluteus, I can do it for hip extension. I can do it onto the gluteus medius for stabilizing the hips to help against hip dysplasia. There were a couple kids with dislocated hips with spina bifida. I got them early, where I was actually able to help to get the hip seated again. And then I also sometimes place the electrodes close to the anal sphincter if the parents tell me that the child has like smearing and they can't really close that sphincter well. So here's another placement when I work specifically for the hips. So that's the gluteus medius placement. And I wanted to show you how strong I can make my stimulation. So this child actively can't do any hip abduction, any spreading of the leg, but I can place my electrode, and mom can even do a little bit of resistance, and he actually keeps it there. In the meantime, he's totally comfortable and playing. This is a child. He was 6 years old when we started, and he basically had practiced crawling all his life. And you can see how his legs are really wide, and it's hard for him to get the knee flexion. And this is him 8 weeks later. We didn't practice crawling at all. The only thing the parents did is they did the stimulation 2 times a day in the car, while they were driving to school, they were both teachers, and he had the electricity on his adductor muscles and his lumbar and sacral spine, and he showed all this really amazing improvement. So for this chart, I worked on his scoliosis. So I'm calling this upper spinal stimulation when I'm getting the trunk or the arms as well. And you see when I'm activating, he gets a lot straighter and his head is up. And then when I let go of the hand switch, then you can see how he falls back into his original position. The head falls back. And then here I'm pushing again, he comes back into the corrected position. So over time, he has this on more and more, especially, for example, his occupational therapist really likes it when he has this on because he can use his hands much better in play. He uses that while he's eating in his high chair. Again, it gives him much more stability. And with time and training, he got better with his trunk strength and position. I wanted to show you an older child. So he's 11 years old because I always get asked, like, is this just for babies? And no, it is not. He is fairly unstable in his trunk. And then this is him 3 months later. And you can see he's a lot more stable. He can rotate his trunk while he is sitting. And for him, it was also really important to do this. He has kyphoscoliosis, so this is kind of moving up his spine. This is the his trunk right now, and it was really in a kyphosis. So it felt like when he started, his trunk was really, really unstable, and it was hard for him to sit without supporting on his arms. And then when we did this stimulation, he was much stronger in his trunk, which I believe probably would also help straightening out his kyphoscoliosis. Another child with scoliosis again, and I wanted to show you kind of, this is, I have the stimulation on right now, and I was really trying to kind of shift his weight over. So right now for him, you see no electrodes on the spine. I basically have one on his gluteus muscle because I wanted him to push the leg into the ground, and then the other ones on the side of the trunk, trying to shift his weight over there. And you see when I'm starting it, it kind of helps him to get a lot more symmetrical. He is very comfortable doing this time. There's no problem with comfort. And you're going to see me here. I'm going to activate the electrode, and you see abdominals coming in. You see the latissimus coming in, and he is correcting his position. Again, you know, I know a lot of us that work with kids with scoliosis, it is so hard to give children the awareness what they really have to activate in order to be in a corrected position. So it is really nice to do that with the electrodes. So the possible outcomes of upper NISE Stim would be increased respiration, decreased respiratory illness, increased coughing force, better trunk extension and co-activation, increased abdominal functioning, preventing or slowing down scoliosis, and improved upper extremity function. NISE Stim is very user-friendly, so the therapist is teaching the parents what to do, how to place the electrodes, and how to start the eStim unit. And the parents basically do the exercises 1 to 3 times daily at home, between like 20 and 30 minutes. They place the electrodes and then they let the kids play. Like this little girl, Laura, she was just playing with her little backpack on, and she was crawling or moving around. I like it when the kids are active doing stimulation. But life happens, like before with the other family, you had 2 children, and those parents were teachers working full-time. They were saying that they could do the exercises on the way to school and on the way back, and it still made a difference. So what is the cost? Basically, the Chattanooga Continuum unit is the one that I'm using. Reason for that is really the best battery operated one, at least in the American market that I know of. It is very user-friendly, and it has safety features that I think are super important, especially when you use it with children that don't have normal sensation. It would cost about $420 US. And then, if it's sent somewhere in the world, then the shipping and the customs is added. I have no influence on the customs. It gets added in that country. The electrodes are about like $20 per month if the therapy is done 2 times a day, and then $10 a month if it is done 1 time a day. And then the physical therapy sessions for NISE Spin, typically they are not as frequent as regular physical therapy sessions. And the reason for that is that really the parents get taught what to do. And once there is a good program, it doesn't have to change that frequently. It basically changes when the child changes. So initially there's more change. That's why I see the parents more frequently. And then later on, I see parents much less frequent, sometimes every 2, 3, 4, 5, 6 months, to follow up, especially when the child is changing. That's when we change like electrode placement or intensity or something like that. I often get asked, how long is the therapy done? And the answer is really, it is done as long as you still get something out of it. So this is another child with scoliosis. He has a S scoliosis. My guess would be that this child would do the therapy for many, many, many months. I have families that do the therapy for a while till they achieve a certain goal that they have with the child, for example, independent walking, and then they stop for a while. And then the child may have too much pronation while the child is walking, and they may start again. So it can start and stop too. When ending the therapy, it seems like the newly gained nerve connections seem to persist. So like whatever new sensation and movements the children got are there if they use it in function. And the same thing is actually true with the muscle strength. So you would get improved muscle strength, and it would stay improved if the child uses it in function. If it is, for example, a child in a wheelchair, where I'm working on hip extension and the family stops and then the child mostly sits in the wheelchair again, then the hip strength, the strength into hip extension, some of that would be lost again. So here I want to show you like abdominals. So this little boy has the electrodes placed on his spine, like his thoracic spine and his lumbar spine, and then on his belly, like in the picture on the right. And he's just playing. And the reason for him, while I put it on his abdominals, as you can see, he really has a pretty strong lordosis. So I wanted him to feel what it feels like to activate his abdominals while he's up and moving. And that's exactly what's happening. So again, it can be coordinated with other therapies. It can be coordinated with play. So I typically want to see responses within 2 to 4 weeks, that there's something changing. Latest within 6 weeks, I really want to see a change. If I don't see that, I would be kind of concerned that something is not right, like not enough frequency or so often I see increased circulation, new movement, strengthening of existing muscles, faster motility, also faster digestion, less constipation, and increased sensation. So that was kind of this cute video that this mom sent me with the cold soda can that the child was able to feel, which before she didn't respond when she was tickled or when she was feeling something cold on her feet. This girl was 18 months old when we started spinal electrical stimulation. She has level L3, L4 spina bifida. She was unable to stand. She didn't know how to push her legs into the ground and was too weak to extend her hips and knees. 8 weeks later, you see her standing up tall. Her hips and knees are extended. The family did spinal electrical stimulation an astonishing 4 to 5 times a day while she was eating or playing or standing. Again, this is what she looked 8 weeks before. And here she is 8 weeks later, standing up tall. By doing electrical stimulation, we strengthened not only her muscles, but also gave her better sensation. So she had a better sense where she was in space. And here are possible improvements over time. So increased sensation, and I think it's a really big deal. So this child on the left is actually a teenager I saw a week before this happened. So we just had started spinal stimulation, and then he went to camp and they didn't put his AFOs on correctly. And he had this major blister, and for months and months, he couldn't use his AFOs and he couldn't stand. So it was quite a big deal. Then muscles responding in areas that were unresponsive at initial testing. Remember how I was saying, I really like to kind of do the initial testing, see what's going on so we can document objectively what has changed. Reduced hip dysplasia. So even I've had a couple kids, 2 kids so far, where they had a dislocated hip. They were young kids, 8 months and I think 9 months. And I was able to get the hips seated using a lot of stimulation on that glute medius muscle. Improved motor function. So I think NISE Stim works hand in hand with all the other therapies. So when the child is able to fire the muscles better, every therapy is going to be easier. Whatever you're doing, NDT or DMI or whatever else therapy you do, is much, much easier once the child can actually activate the muscles. And that's kind of where I feel I come in. Then reduced asymmetry, right versus left side, and then faster healing and less fungus between toes due to toe spreading. So the faster healing would be actually because of better circulation. And the spreading of the toes is a big deal for the teenagers that have like braces on all day long. There tends to be a lot of issues with skin breakdown. And when they spread the toes and they're not crunched together this much anymore, that also helps them with having less skin breakdown.
I'm just noticing how much more extended this leg is than this one. Like, I knew they were always sort of a bit different than each other, but this one's seeming like this muscle is still a lot stronger. And I wonder if that's okay about the asymmetrical.
So here's
sort
the
of
stimulation coming on, and I was saying,
contraction.
no, it is not okay. I don't want it asymmetrical. So then we changed it. So now stim is coming on, it's
So
symmetrical.
that's now it's 73, 50. So 73 and 50. Yeah, let's say that's pretty even, eh?
So the stimulation is off.
Watch one more time.
And then you can see this is her own movement that she can do. So she's just kind of flexing. So now it's slowly
Oh.
coming on, it's ramping up. And
Go.
it's on for 10 seconds, and you can see how we got it nice and symmetrical. So this child, the father actually called me on the day she was born. We started at 3 months old, and I can just address any kind of asymmetry in terms of positioning or of muscle strength or muscle firing as early as possible. So it is not as big of a deal later in life. This is Ava at 10 months old. She has level L2 spina bifida. She has weak gluteal muscles and weak hamstrings. So she cannot put her legs into the ground to sit up tall. Here you see her 8 weeks into doing spinal electrical stimulation. And you can see how she's a lot taller, but she still needs to have at least one hand on the ground.
Good job,
for
well
balance.
done. Look at that balance.
So as comparison again, this would be a pretty typical position for kids with weak glute muscles. And then here you see her 5 months later at 15 months old, and she has gained really good stability through her hips. And she can even lift her hands off and over the ground while she is playing. So I sometimes get asked like, oh, isn't that just normal development? So she was 10 months old when you first saw her. No, it is not. I know no child was 10 months old who has a normal nervous system sits, just folded over the way she was folded over and needed to push her hands in the ground in order to be able to sit up. And then the gluteus muscle is like a L5 muscle. So often for children with spina bifida, it can be impacted. Actually, it's impacted in a lot of our kids with different impairments. So when I was saying being able to activate a muscle that was inactive before, that was exactly what was true for this child. Once we were able to get her gluteus and her hamstrings to be more active, she actually was able to sit up and use her hands in play. There can be changes in bowel and bladder using NISE Stim, but I estimate that that is only in about 20 to 30% of the children that start the treatment. So while I know this is always very high on the wish list for families to get improvement with bowel and bladder, that is something that I cannot promise. But it does happen. And when it happens, these are the things I'm seeing. So it would be improvements in anal tone with less fecal smearing. That would be something I see easier. That is kind of a little easier to treat. It's basically a muscle, right? It's a sphincter muscle. To get that muscle stronger and have more tone, less constipation, virtual recognition to use the bathroom, erections, ability to push urine or stool out, continence, and improved bladder pressures. And there has been quite some interest. I know there are some clinics that actually implant electrodes specifically for the bladder to kind of help people to gain bladder control. So there's a lot going on there right now. I have had 2 urologists that kind of reached out because my patients were also their patients and they had seen improved bladder pressure. And I hope with the help of people that understand that area much better, like urologists or pelvic floor physical therapists, that will be able to fine tune this protocol and be more successful with addressing this area as well. Which patients would be appropriate for spinal electrical stimulation? Basically, people with peripheral nerve damage, like plexus paralysis and spina bifida, but also central lesions like cerebral palsy or other neuromotor impairments, or children, for example, with spinal muscular atrophy if they were treated. Contraindications for spinal stimulation and electrical stimulation are implanted electronic devices like the vagal nerve stimulator, the baclofen pump, the pacemaker, unless with the surgeon's permission. It is not the magnetic devices, like sometimes you have a VP shunt that can be adjusted magnetically. That is not a contraindication. And then pregnancy, because there is no research done on pregnant women showing whether it is or is not harmful to use electrical stimulation. Precautions are hardware that is conductive. So if there would be a child that has a spinal fusion, I would not choose to put electrical stimulation over the area of the fusion. Seizures, currently there are research studies out there not showing any links between increase in seizures and electrical stimulation, but they still have that as a precaution. Cancer, thrombosis, heart rhythm issues. So if I have a child with heart rhythm issues, I do not place my electrodes on the front and back where the current would go through the heart. Impaired skin, nerve irritation, and cause and effect, wrongly blaming electrical stimulation. Thank you very much for your interest in NISE Stim. I hope I was able to present the main points about the therapy. I think it is a pretty exciting therapy that just can advance patients more than the traditional physical therapy could do so far. My goal is to do a lot of teaching, to teach other therapists what I know, and then with their knowledge, they can use that on their patients. So while I'm really focused and specialized in children with spina bifida right now, I have many colleagues who have taken my course who treat children with spasticity or cerebral palsy, and telling me that they're really successful using NISE Stim as well. I will be teaching quite a bit this coming year. All the teaching places will be on my website. So now I want to open up for questions and answers. Please, if you have a very specific question for your child, that might not be the right platform to ask right now. If you have a more general question that might be interesting for everybody, then please go ahead and ask. You can unmute yourself. Okay, so let's go see. Here we go. And so Nicole has been looking into the chat a little bit to kind of see what questions came up. So I wonder if it might be good for Nicole to kind of ask those questions first, whichever ones you think might be pertinent. And then for the audience, if there are more questions out there, please go ahead and ask.
Thanks so much, Gerti. That was really informative. I saw many of the questions in the chat being answered as the presentation went along, but I did write some down. The first question would be, is NISE Stim appropriate for children with other impairments? And there was a specific question also relating to myopathies.
And the specific question was related to, what was the condition?
Myopathies.
Myopathies. So that might be probably one that I would have to research before I could answer that, the myopathies. So Dr. Alan is the researcher, so whenever I have a question, like I don't know an answer, I go back to him and say, okay, is there anything in the research that shows that you could use, you know, electrical stimulation or spinal stimulation in myopathies? And he would be the one being able to tell me if there has been anything published in that area yet. So I would have to table the question for right now.
Yeah, that's great, Gerti. And definitely for other impairments. So as Gerti have mentioned, for cerebral palsy, we've definitely been seeing improvements in our patients and in gait patterns. And there was a question relating to children with autism and toe walking.
So, I mean, it wouldn't treat autism, right? That is, and I know I have a colleague who has used electrical stimulation or spinal stimulation on children who are toe walkers just on a sensory level, just to kind of see if that gives them enough input to change that. And she was saying it's a hit and miss. So either it works right away, and then it's something you can use. But if you place them on there and nothing changes, then that is just not the input the child needs.
Because sometimes there's other things relating to the toe walking, right? That's not just muscular.
Right, yeah.
So there's another question wanting to know the different types of spinal stimulation and what sets NISE stimulation apart from the other types of spinal stim.
Yeah, and I think one of the reasons why I'm now using NISE Stim, I'm really just starting this year, is to distinguish myself from other spinal stimulation. So if you look up spinal stimulation, there's, for example, another person, her name is Susan Hastings. She does great work. She calls it spinal stimulation or neuromodulation, but it's very different from my approach. You know, we have vastly different approaches and vastly different philosophies. She works a lot with children with cerebral palsy, and she has published quite a bit in that. So she does great work, but I wanted to know that people understand the difference, and that's why I thought it would be important to use different names. So I work with much stronger muscle contractions. I really go for muscle contractions, muscle strength, while, for example, she would work on a much, much lower intensity and more on the sensory level.
Thank you, Gerti. There's a question asking, how can we get access to the device that you use in your therapy? And how is this device different to TENS?
So the device in United States, you can just, go on the internet and kind of look it up. And I believe you can also get it in Australia, the Chattanooga Continuum. So those are the two countries I know you can get it. Unfortunately, in many other countries, you can't get it. And I know you, Nicole, even asked in South Africa, Chattanooga, the company that is there, if they would carry that device. And I think it has something to do with getting that as a medical device in different countries that can be really expensive. And that's why they sometimes choose not to. So then what people do that really want to have the device is they can order that from me and I can send it. We are looking also into other devices. Nicole and I, we were talking yesterday. There are devices that would be not as good as the Chattanooga Continuum, but they would be a lot cheaper for the parents. My first preference would be always the Chattanooga, but if for some parents it would be like I either can buy something that is a lot cheaper or I can't do this at all, then I think the idea is to provide the patient with a unit that may not have all the different functions or may not be able to be kind of programmed as delicately like my machine can, but at least they can still do some stimulation with their child.
Thank you. There's a question relating to joint contractures and whether there's a precaution in using the device when the child does have contractures.
No, there isn't a precaution, but it is also the stimulation alone is not going to help the joint contraction. So when you saw the child like with the clubfoot, he still had the range. And so I was trying to really activate the nerve and the muscles that help the child pull, the little toe side up, like pull out of that clubfoot. I can do that. Or I can, for children where I know they have the tendency to have too much plantar flexion, so the toes would point too much, I can stimulate the muscle that pulls the toes up. But if the joint is stiff and can't go further, then I'm limited there too. So, but in combination, it actually works really well. So very often when you work on range, unless you have a muscle that then can activate and help the child to use the new range, you get stiff again. And that's kind of where I'm coming in.
Thanks, Gerti. There's a question for the success rate specifically of patients with Spina Bifida and myelomeningocele. And then just to combine with another question, they asked, would it benefit a patient that has absolutely no movement in the lower limbs?
If that patient has Spina Bifida, I would think so. So for the most part, the nerves aren't completely severed. If they're completely severed, which happens apparently very rarely, but if they're completely severed, then I'm out of luck too. Then I can't really help with my stimulation. But if there's even a faint nerve signal, I can still try and see if I can get more.
Okay. Is it possible to overtreat?
Yes, absolutely. So I think it's really important to start slowly. And I always compare this a little bit with people training for a marathon. I think it's really important not to advance too fast. And if you advance too fast, you actually would slow your progress. So when I get started, I typically start between like 15 and 20-minute sessions. And typically we have like 10 seconds stimulation on, and then 15 or 20 seconds stimulation off. And at the beginning, also, I don't increase my intensity as high. And then over weeks, we slowly increase all of that as the child's endurance increases.
There's a question, can you work above the level of injury? In example, in the neck for head control.
So can you work high enough to help out with head control? So if I would work on head control very often, I would probably work on trunk control. So I would have electrodes on the trunk. You can go all the way up to the neck with your electrodes. A lot of kids don't really like the electrodes up on the neck. You can do it. It's safe. A lot of kids, they have like the little hair there and they get stuck in the electrodes, whatever. Don't really seem to like it a lot. However, since the electricity goes up and down the spinal cord, so even if I'm like below the cervical spine, the electricity will go up through the cervical spine to the brain. So I would still stimulate that area. So when I had like kids with plexus paralysis, where technically the damage is in the cervical spine, and I placed my electrodes below that, I could still activate that muscle.
There's a question, when is it the best time to start NISE Stim, and is it ever too late?
So the best time to start is when the child is medically stable. So I had like a colleague who started with a child with plexus paralysis, and that child was 17 days old. I have started as early as 2 months old. So those were kids that were had the surgery in utero. So when they came out, there was already a lot of healing of that part of the spinal cord. My limitations are always two limitations. One is the skin. So if the skin can get irritated. If I'm on there too long or too high, it can get irritated, and it would basically be an irritation like a sunburn. It would stay red longer than 30 minutes. And so when I know that, then I just have to do the stimulation less, or less intensive or shorter, or use different electrodes or do a different placement. But there can be, so that's one limitation. The other limitation is pain. I do not increase my intensity to anywhere where it's uncomfortable. So I always have to make sure it stays comfortable for the child. And sometimes they have children that have a lot of sensation, and they just don't want me to go as high as I would prefer to go with the intensity to see a muscle contraction. And that is just a limitation I have, and I will stay with whatever is comfortable for them.
The use of NISE Stim for traumatic spinal cord injuries.
So I've treated 2 children with spinal cord injuries, and you can use it for that. Yes.
And then how do you know when it becomes too painful for the child to tolerate?
I mean, any signs of pain. So if I have a baby who's non-verbal, I mean, I would certainly look if there's anything that the child is showing me that it is uncomfortable. I always ask the parents, they know their kids really, really well. And then otherwise, I mean, the kids, of course, would tell me that it doesn't feel good.
There's a question, can NISE Stim reverse the injury over time?
It doesn't reverse the injury. You still have the injury. But what it can help is, the nerves to kind of connect better. That's kind of the part for kids with spina bifida. That's kind of the part I'm really trying to work on, but it doesn't reverse the injury.
And then there's some questions relating to specific patients for online therapy with you, Gerti. So if you can maybe give some guidance as to how people can reach you or book sessions with you.
Yes, and the easiest is to get on my website, and that is actually both on my Instagram is my website. It's spinalstim.net. I have all that information there, like how to get a hold of me, how to buy an eStim unit, how to book. All my sessions will be booked there. And for people that just have a question, like if their child is appropriate to start this therapy, I now request that I have a online consultation with each parent before they start. So I kind of want to make sure that people's expectations are realistic, that I can provide the therapy for their children. So before we start, I ask the parents to send me like several videos of their child, and I review them, and then together with the parents kind of talk about what would be good for their child and if they are a good candidate for the therapy.
Thanks so much, Gerti. That's the end of the questions. I'm not sure if there was anything else that you would like to mention, Gerti.
Okay, well, let's see if anybody wants to unmute themselves and ask any question, and then we'll see. If not, we'll go from there. Okay, let's see here. And that probably came a little unexpected for people, but okay, let's see. Is there another one in the chat?
Yes. When when you have families come to visit, how long are they staying to establish their at-home protocols?
Okay, great question. So I love working together with other physical therapists. And so my favorite situation is such if people don't live anywhere close where they could come on a regular basis, and that their home therapist takes my online course, my in-person or online course before the child comes. And then the child comes here for like between 2 and 5 days, depending on what the family wants to do. And then during the 5 days, especially towards the end of the time, we do a session together with the home therapist who already knows a little bit now about NISE Stim, and so that she or he can continue and advance the therapy at home. And that seems to be working really well as a concept. Right. Well, I thank all of you for your interest. And yeah, if there are any other questions, you can always, send me an email, especially if they're more specific, to your child. Oh yeah, there's one more person. What is this?
They are thanking you.
Oh, thank you very much. And I'm also really, really thankful to Nicole to get all of this organized, and I'm really excited to coming to South Africa in a few months, and I am excited to teaching at the other places, which is going to be in Houston, Texas in a couple weeks, and then it's going to be in Tampa in February, and then it is in South Africa in March, and then it's in Boise, Idaho in April, and in Colorado in May. And then I'm actually coming to Germany in September and October. So a lot of things are happening right now.
Wow.
Yeah, so let's
That's
see.
so exciting, and I can really just vouch how incredible it is to work with Gerti, and your passion and just care for the patients overflow, and even the ones that you haven't even met in person that's here with us in South Africa. It's been just incredible to see how much you care, and then just your expertise and how much you've committed to this research. And it's such a privilege and an honor to work with you and be able to share in that, because I can just imagine what has gone into actually being able to get to this point. So thank you so much for sharing all of this with us. It's a privilege.
Thank you so much. Thank you so very much. And have a great day, everybody.